Okay, so let's look at the ECG at the basic level. This is how it looks, and now let's learn some things about it. So we have the first wave. This is the P wave, and if we look at the heart, the P wave is correlate with the electrical signal in the atriums, which are the superior part of the heart. This is the left atrium, this is the right atrium, and the electrical signal that goes from the SA node, which is the main pacemaker of the heart, to the AV node, which is the second pacemaker of the heart. The flow of this electrical signal is presented in the ECG by the P wave. After this, when the signal comes to the AV node, it goes through the bundle of His and then through the bundle branches and then to the Purkinje fibers, and the electrical signal in this part from the AV node to the ventricles is represented by the QRS complex. This is known as the complex of the ECG. After this, when the electrical signal in the heart relaxes and the heart repolarizes, we have the T wave. And we have intervals in the ECG. So if we look at a little bit bigger, like this, we'll be able to see the intervals. So this is the P wave, this is the Q, this is the R, this is the S, and this is the T. Now, again, the Q or S is correlated with the electrical signal in the ventricles. The P is correlated with the electrical signal in the atriums. So we have intervals. Here is the interval. This is called the PR interval. It's an interval that is involved in some pathologies in the heart. There is prolonged PR. Prolonged PR is defined as PR above 200 milliseconds, and we have shortened or short PR, which is below 120 milliseconds. Prolonged PR is known as first degree AV block, and we are not getting into it now. And shortened PR can be in Wolff-Parkinson-White syndrome, pre-excitation syndrome. Wolff-Parkinson-White is a type of this. Wolff-Parkinson-White syndrome is when there are also arrhythmia with this. Okay, so the PR interval is quite important. Another interval that we can have is the QRS interval. QRS, which should be under 120 milliseconds. When it goes to be QRS above 200 milliseconds, it is known as wide complex ECG. Wide complex, no, not 200, 120. Wide complex QRS can be seen in many pathologies. Bundle branch block can cause it. Ventricular arrhythmia, when the electrical signals come from the ventricle, it looks as a wide complex. WPW can cause it. Bundle branch blocking, we said. Yes, okay. And even we are classifying the tachyarrhythmia. If you look at the AHA, American Heart Association algorithm for tachyarrhythmia, it is divided there to narrow complex tachycardia and wide complex tachycardia, which is exactly this. It is based on the duration of the QRS complex. When it is above 120, it's wide complex. When it is below, it's narrow complex, and we give quite different treatment for each, because if the electrical signal comes from the atrium, we have medications like adenosine, verapamil, beta blockers, which works on the AV node and block the signal there. But if the signal comes from the ventricles, so the complex should be wide complex, so treating the AV node wouldn't change, because the problem is in the ventricles, which is below the AV node. So it's quite important. There are some pathologies like bundle branch block, which do cause the AV node and comes from the atria, and there is just block in one of the bundle branch, which cause the QRS also to be above 120 milliseconds. That is why in the algorithm you can see that it says that if the tachyarrhythmia is wide complex QRS, but it is monomorphic and regular, you can also try to give the patient drugs that blocks the AV node, like adenosine. You can try it, and maybe it works and maybe it won't work. Okay, so this is the QRS complex, the QRS interval. It's quite important. Another interval that we have is the QT interval. This is important for pathologies like long QT syndrome. Now, what is the normal QT interval? It is defined in women to be until well, let's say it's around 450 milliseconds to 470 milliseconds duration, QT interval. But QT interval needs to be corrected, and that's why we need the QTC interval, QT corrected. And there are ways to correct it. There is a formula, you can look up for it, but in most modern ECGs you are getting the value for the QTC. And when I say 450 to 470, I mean to the QTC interval and not to the QT interval. It depends on the heart rhythm. When it is slow, the QT might be longer. When it is high, the QT might be shorter, and we need to correct it. And the QTC value correct exactly this, and we get the right values. Okay, another interval that is important is the ST interval, which is important in some pathologies like ST interval. But now what happens with the ST interval? It can move. We are not talking about the duration, we are talking about the place of the ST. Like, look at this, or maybe, wait a sec, okay. Right. Oh, look at this. We have the T wave here, we have, okay. And what happened to the ST segment? It elevated. This is ST elevation, and it is seen in some pathologies like STEMI, which is ST elevation myocardial infarction, which is a myocardial infarction where the signs in the ECG for the myocardial infarction is the ST segment elevation. We also can have ST segment depression, which can also be seen in ischemia of the heart, like in myocardial infarction, but sometimes the ischemia is milder. Or we are looking at the ECG at a place which reflect the place where the ST is elevated. Like if we have a ST elevation in some leads in the ECG, we have in the corresponding or the parallel leads ST depression, which is like a mirror. Let's see. Here it is. Okay, so this is an ST depression. No, this is an ST depression which can be seen in pathologies like partial ischemia. But not only this, there are also other pathologies we can call ST elevation, like pericarditis, which can cause diffuse ST elevation in all the leads, in contrary to ST elevation of ischemia, which cause part of the leads to show ST elevation and part of the lead to show ST depression. In pericarditis, it shows usually diffuse ST elevation, which is one of the hallmarks of pericarditis. Not only the ST segment can change in position, but also other intervals. The PR interval, or this segment, can show depressions, which is called PR depressions, again in pericarditis. This is one of the pathologies that can cause PR depressions. So let's try to sum up it a little bit. We have the P wave, then we have the complex QRS, then we have the T waves. The P waves correspond to the electrical signal in the atriums. The QRS complex is correlated with the electrical signal when it comes to the ventricles. And we have the T waves, which is correlated with the electrical signal that repolarize. This segment, PR interval, we talked about it. It can be short, it can be long, but what does it mean? What does the PR interval mean? Why it is there? The reason is that when the signal comes through the SA node to the AV node, this is the P. But after this, it gets to the AV node, which sits here. And what happens in the AV node? There is a pulse in the AV node. The AV node make the signal wait a little bit before it goes on. This is important. It is important in many pathologies, and it is important phenomena, like in atrial fibrillation, when the atrial rate can get to 500 beats per minute. This is very high. If every beat in atrial fibrillation would have gone through the AV node and to the ventricle without any pulse in the AV node, the person would have died. So what the AV node does, he has a refractory period. He's not letting all the signals to go from the atriums to the ventricles. It pushes it a little bit, and this is the PR interval we can see. So the AV node uses the pulse, the AV node uses the refractory period in order to pass part of the pulses or pulses until limited rate to go through the AV node. So this is the PR interval, and this is the waiting of the signal in the AV node. Okay, so P is the contraction of the electrical signal in the atriums. PR interval is the segment which halt in the AV node. QRS is the electrical signal in the ventricles. And the T is the repolarization of the electrical signal of the heart. And we talked about a little bit about the intervals. PR intervals, when it's long, it can be sine of AV block type 1. When it is long, above PR, above 200 milliseconds. When it is short, it can come with the pre-excitation syndromes like WPW. It can depress, and this is seen in pericarditis. And okay, there are also more pathologies like the P wave can be absent. It happens in atrial fibrillation. It happens, I think hyperkalemia can also cause that. Hyperkalemia, which is a high levels of potassium in the blood. Okay, we have the QRS complex, which is the electrical signal in the ventricles, which can be prolonged, which is more than 120 milliseconds. This is seen when the electrical signal comes from the ventricles, or there is a bundle branch block. Other things can also do that. We have the ST segment, which can be elevated in ischemia or depressed. It's not just ischemia, there are also other things that can cause it, even benign things that are quite common, like benign early repolarization, or that cause the ST segment to concavely, like this, up concave, to go up. So it's like, it's like something like it seems like something like this. It happens in young, healthy adults, especially athletes, and it's sometimes hard to differentiate it from myocardial infarction. But if you see a very healthy young adult that feels fine without diabetes or something, and don't have any problem with the neuropathies or something, and he had these signs, it may be just benign early repolarization, which is quite benign most of the time. Okay, we talked about the QT interval, which when it is prolonged, it can sign QT, prolonged QT interval, which can be with a sudden cardiac, related to sudden cardiac death. If you want, you can read about prolonged QT syndrome. We have the T wave, and I didn't talk about T wave too much. There are some pathologies that can be seen in the P wave, like it can look like this, which is inverted T wave. It can be seen thin in a myocardial infarction. It can be seen in a pericardial pulmonary embolism. It can be seen in hypertrophic obstructive cardiomyopathy. Many pathologies can invert the T wave, and it can be even normal in V1 and AVR leads, and it can be in young children, even in VISH times sometimes. There is also peaked T wave. When the T wave is quite peaked, it can be seen in hyperkalemia, high levels of potassium in the blood. Another thing that I want to show you is absent of the P wave, or P wave that look like this. It can be seen in atrial fibrillation. Okay. I didn't talk too much about the Q wave. Sometimes when the Q wave is quite prominent, it can be a sign of previous myocardial infarction. Okay, so we played some with the ECG. I played it with it and explained on some of the pathologies, and can be seen in order, mainly in order, to show you the P, Q, R, S, T, and the intervals, that you can remember this. So this is a basic ECG, but mainly about the waves and the complex and the intervals. I didn't show you irregularities, tachyarrhythmias, bradyarrhythmias. Mainly I was focused on the complex itself and the waves itself and the intervals themselves. Okay, thank you.